Preparing live stream.
This is the part that we always say, Maureen, this is going to be our blooper reel.
Yeah.
Because
Funny.
we can never, I'm pretty sure that we're probably live. It shows Facebook
Yeah.
on here. So if you were seeing this part, you're likely seeing the replay. So welcome to our recording of our latest podcast. You're going to see a new face here. We're going to introduce here in just a minute. So if you're catching this on Facebook, let us know that you're tuning in live, or if you're catching the replay, you get to join us today for another episode of Motherhood, Menopause, and Mayhem. So we are going to get started right now. Welcome to Motherhood, Menopause, and Mayhem, the podcast where motherhood meets midlife mayhem and menopause gets real. I'm Carla. I'm a menopause specialist. I'm a mama of 5, and always your go-to for sharing way too much information, but it's going to be really good today. Christine.
Yay. And I was like, Maureen's the one that's going to be sharing way too much information today. So I'm so excited to have Maureen here. I am the midlife mom. I love helping women take back body confidence in midlife and menopause with simple habits and no BS. And so we have been working on having this very special lady here, Maureen McGrath, to talk to us today because she is an absolute powerhouse on menopause, vaginal health, all the things. We're going to be having a really awesome conversation today. So she is a registered nurse and she is a vaginal health expert. She's got her own podcast, which is really gaining some serious ground, called Sex, Health, and Relationships. She's a radio personality and she delves into the intimate intersections of sex, health, and relationships on her podcast. She's got a decade of experience behind the mic, and she's always got insightful advice, expert interviews, and candid discussions, which we're going to have today. So welcome, Maureen.
Lovely to be here, ladies. Thank you so much for having me.
We're
Yes,
thrilled
yes.
that you were here today.
Yeah, absolutely. So why don't we kick it off with, how did you find yourself in this? You're a registered nurse, so you've obviously got a health and medical background, but how did you move into this space of vaginal health and all the other things that we're going to talk about that you're doing right now?
Well, I'm a registered nurse, as you mentioned, and a nurse continence advisor and a sexual health educator. And I have a lot of experience in clinical trials, especially in low sexual desire, erection function, arousal, orgasm. And so that's my background. And I've been working with OBGYNs and urogyns and general practitioners for a number of years. And this was an aspect of their clinical practice where there was a gap. And so I had this experience around helping women who leak urine, and may I say, leaking urine is never normal. And so when you're down in that area, you discover other things, like many women, about 70 to 80%, experience vaginal dryness or other symptoms of vaginal health, especially at perimenopause and menopause. And they may experience burning and urgency and itching or postcoital bleeding. And so, I started incorporating my nurse continence advisor with my sexual health experience and realized that many, many people needed help in that area.
Yes.
Absolutely. And,
Yeah.
can you do me a favor, Maureen? Can you explain nurse continence?
Nurse
What
continence
is
advisor, yes. It's an advanced practice registered nurse. So I have certification from McMaster University, and I am able to provide an assessment, contributing factors, ascertain the contributing factors, and provide a nursing diagnosis for the different types of urinary incontinence. And why that's important is because you have to understand and know and diagnose appropriately the type of urinary incontinence one is experiencing in order to be able to treat it appropriately. Not everything can be treated with Kegels. In fact, very little can be treated with Kegel exercises.
So I should not
appreciate
bother
you.
going
Well, yeah, I saw that. I actually wrote it down after I was looking at your Instagram page. I was like, Kegels. It's not all about the Kegels. I wrote that in my notes, but I thank you for explaining your position and where your background is, and especially that I don't want to monopolize this part of the conversation, but especially that you mentioned that incontinence is not, like leakage is not normal. I don't know that I've ever heard someone say that that's not normal versus, well, you know, you're in perimenopause, or you've had 4 kiddos, or this is just kind of part of it. So I appreciate you putting that out there so that we can understand and be educated that it's not normal and we may need to seek some support in that area. So thank you for bringing
Absolutely.
that up.
Yeah, and according to research, it takes a woman an average of 7 years to actually seek treatment about her urinary incontinence, because many women think that it's normal. And about 50% of women will experience urinary incontinence, whether it's leaking with coughing or sneezing or exercise or moving in bed, to urgency with incontinence or overactive bladder, or retention. They might have overflow incontinence. So they experience, and it's very debilitating actually, and it can really impact quality of life, especially at a very young age, whether it's postpartum related to vaginal deliveries or not. Women who've had a cesarean section can still experience urinary incontinence, or whether it's related to perimenopause and menopause and postmenopause as well. That's actually part of the genitourinary syndrome of menopause that many women experience, in the years leading up to menopause, and beyond. So it's very important, and the diagnosis is critical as well.
So what is
Thank you.
actually happening? Like
Yeah.
what's actually happening down there during,
Well,
like if you're talking about menopause and postmenopause?
sure. What's happening is there is a decrease in the estrogen receptors in the urogenital tract. Now that sounds like a mouthful, but what happens is estrogen, as you know, in the 30s and 40s can start to decrease, and not only systemically, which may lead to hot flashes and night sweats, but it can also decrease in your bladder, your urethra, your clitoris, your vagina, the folds, the labia. And so it can lead to a number of symptoms like vaginal dryness, like urgency with incontinence, painful sex, dyspareunia is what we call that. And that can lead to low sexual desire. And then that can lead to relationship problems. And so you see, it's very important that women get this treated. And there are some very simple fixes for it as well. And that's another thing, that a lot of women feel that there's no treatment for urinary incontinence, or they say they've Kegled till the cows came home and nothing changed, or they've, been Kegling for a year and a half and nothing has changed. Don't get me wrong, pelvic floor physiotherapists are critical in treating urinary incontinence, but they go well beyond Kegel exercises as well.
And so what can we do?
What one can do, I mean, it's okay to do Kegel exercises and do them properly. Like a lot of people I see, influencers will say, well, women don't know how to do Kegel exercises properly. That's why they're not working. Buy my program. That's not true. Women are very smart. It's very simple. It's actually squeezing the rectal muscle to the count of 3, the muscle that prevents you from passing gas. So squeeze 2, 3, hold 2, 3, release 2, 3. And you can work yourself up to a set of 10, 3 times a day, if you like. If that doesn't change things, if it's related to decreased estrogen and that has led to some dryness and thinning walls, then you might begin with a personal moisturizer. And so I recommend Femme, which is a gel, and it's very hygienic. It's PHEMME, and it's inserted into the vagina. And so it comes with a plunger, which is very nice. It's always important to wash your hands before inserting anything into your vagina. Hand hygiene is so important to prevent infection. And another one I recommend is Repagyne, which is a vaginal suppository. And sometimes that's all it takes to actually repair the tissues, to help bring back the moisture and the elasticity, and to increase the blood flow, and to help to prevent that urgency that you might have, or leakage of urine. But if that doesn't help in perimenopause, menopause, and postmenopause, low dose localized estrogen therapy will. It's very important to restore the estrogen in the urogenital tract, and that can be done using a cream or a tablet or a ring, which stays in for 3 months, and it's inserted and removed by the healthcare provider. You need a prescription for localized estrogen therapy. There's also DHEA, and there's another tablet, ospemifene, which can be used as well. And that's an oral tablet. Sometimes systemic hormone therapy will help with the vaginal health and the bladder health, but I find more often than not, it doesn't. So not all women experience this, but 70 to 80% of women will, and they don't know what's happening. They don't talk about it because they're embarrassed. They don't even talk about it with their intimate partners. But, sex begins to decrease because it's painful, or even if they do speak about it with their intimate partners, the partner doesn't want to engage in anything that's painful as well. So that can lead to a sexless marriage, which is what my TEDx talk was about. And I'm happy to say, and I'm really not trying to pat myself on the back at all, because it wasn't the greatest talk, but it has had over 36 million views, and all that
Oh,
is that it underscores the importance of talking about subjects like this, which is why I'm delighted that you ladies have invited me to discuss this, because, there's a lot of people who are embarrassed. There's still a stigma about sex, vaginal health. You don't go to a dinner party and someone says, "How are you doing?" "Well, I'm leaking urine and I've got a dry vagina. How are you?" That just doesn't happen. But you might talk about your financial problems, or you might talk
yeah.
about other issues that you have. But some of the most important issues are these intimate health issues that women experience. But we don't talk about it. But I'm glad to see that 36 million people wanted to tune in to that talk about the no sex marriage, because ultimately vaginal dryness, painful sex, urinary incontinence, recurrent urinary tract infections can all lead to sexless marriages and the breakdown of the family.
Sure.
Yeah.
And Maureen, by all means, pat yourself on the back. 36 million views is nothing to shy away from. And you're right. It is, the conversation around this, that's what Christine and I and you as well are trying to get into our communities, is that it is okay, kind of releasing that stigma, but talking about communities. I see it all day long in the communities that I'm part of. I'm sure you see it as well, where women are asking, they're showing up anonymously or with their name attached to their social profile and asking the questions about some of the things that you just described. And first of all, what I want to say, we didn't do our disclaimer, but I want to say this is for educational entertainment purposes only. We're not here to treat or diagnose or cure anything. So I want to throw that out there. Make sure that you're talking to your provider if you are having some of the things that if you're experiencing some of the things that we're talking about. But Maureen, when you're talking, you mentioned a lot of different things, different paths that people can go, different types of tools, and some were prescription based. Were the first two, the Femgel, and I didn't write down the other one, were those over the counter?
Repagine, Repagyn. But I must also say that the first line also is a lubricant during intimate moments. And so, it should be common practice that women use a lubricant, and something like Astroglide, a water-based lubricant is very good, is something that I would recommend. Just a good, solid lubricant. So very important. Lubrication, personal moisturization, which is different than lubrication. And typically with personal moisturization, as in the Fem or the Repagine, we recommend, a week, nightly for a week, and then 2 or 3 times a week at night. And, I like to say it's just as important to moisturize your vagina as it is your face. And it actually works better because of the submucosal tissue. It gets absorbed in there. So it's very important to moisturize your vagina. And because the estrogen receptors decrease as women age, it may happen in the 40s, 50s, 60s, 70s, 80s. A woman may not experience vaginal dryness even up into her 70s. And then all of a sudden in her 80s, she's starting to experience symptoms. So, and it's never too late to treat vaginal dryness or genitourinary syndrome of menopause.
Thank you. And when I was talking about the communities, and women are asking these questions all the time, and you've given us a lot of solutions. What, not that I think I would get into the conversation necessarily about this is what you need to do, but you see oftentimes, and maybe it's because they don't, we started this conversation off with women don't know that it's not normal to have these symptoms. And when is there a line that you would say that it's safe for a woman to treat, and I'm using air quotes for those listening on podcasts, to treat something at home versus, okay, ladies, it's time, you need to go see a specialist about this?
Well, one of the problems is social media. On one hand, it's done a tremendous world of good, raising awareness about these issues. On the other hand, there's a lot of influencers that are selling products and selling solutions and, selling hope to desperate women. And so, you really want any type of management, if you will, or treatment, to be evidence-based. And, sometimes Dr. Google can be a friend, and sometimes Dr. Google can be a foe. And so it's really important to speak to a healthcare provider, somebody who actually sees patients, diagnoses patients, treats patients, and follows up with patients to see how that worked. And so it's just for somebody to, read a few books, but never lay their hand on a patient. It's just not appropriate to garner information, especially about your health, from somebody like that. And you can go on and be utilizing a program that you've bought on social media for a year and have absolutely no results. And in that time, that could have impacted your quality of life. Now, I must say that physicians haven't been given a robust amount of information in terms of treating incontinence or vaginal dryness even, or low sexual desire. And this requires education, which is, I had actually worked with some very forward-thinking physicians, which is why they brought me into the clinic, because they realized this is education. It takes time. It takes comfort. Sometimes they weren't comfortable speaking with a male physician, although many times they can be, and some male physicians are up to date on this. But so it's very important that you get your information from a healthcare provider, not somebody who is saying hormones for everyone, or, buy this product, or, you must wear that in order to increase, your bone density, for example. So that I think is very, very important. And there's no shame in it, no stigma. And, it's a place to begin. And if you don't get much from your GP, ask the GP, is there somewhere I can go? A pelvic floor physiotherapist is a great option. If you've gone 3 times and there's no change, maybe it's time to look for another, person who deals with urinary incontinence. Another option for treating urinary incontinence is a pessary. It's a medical grade silicone device that's inserted into the vagina that supports the mid-urethra where the weakness happens as a result of the decreased estrogen. I fit them in my clinical practice. And, that's a great option, especially for runners. A lot of women, after they've had a baby, they can't resume running because they're leaking. But this can be self-managed. It can be put in and taken out. So there are so many options available. And it's great to speak to a menopause physician, a nurse continence advisor, pelvic floor physiotherapist, but somebody who's certified, somebody who's trained and actually sees patients.
Fantastic.
I couldn't imagine talking to my personal GP. He is just not on the radar with this stuff at all. But there are a lot of I think, and this is kind of leading into the HRT thing. Carla, did you have anything else you wanted to talk about on the?
Nope, that was good. A lot of great information. Appreciate it.
Are we wrapping up the vagina? Because I just wanted to mention.
Oh, yes.
Go ahead.
Okay. Well, the reason that it's very important, the reason it's very important to have a healthy vagina, and this could be the most important information on today's podcast, is that we rarely talk about women's pleasure, female sexuality. There's a double standard, for men versus women. It's shamed for women. It's applauded for men. And so it's oftentimes, in addition to leakage of urine and vaginal dryness and low sexual desire, it may take a woman longer to experience an orgasm at midlife. And so, pleasure is very, very important. And so a healthy vagina is important as well, even to be fitted for a pessary. But also, 70% of women require clitoral stimulation in order to experience orgasm. And so, this is an example of a clitoral stimulation device. It's, very lovely, and it does the trick. And so it's important that women understand that to have a healthy vagina, you can have a healthy sex life. And so, I also get from a lot of women, I'll ask them if they have vaginal dryness, and their answer will be, I'm not married, or I'm not in a sexual relationship. And you do not have to be sexually active with another human being in order to experience vaginal dryness. But, for women who are on their own, who have self-stimulated or have used a device like a clitoral stimulation device, it's important to understand that your vagina needs to be healthy because the blood flow is flowing, there's elasticity, there's moisture, it's helpful for arousal, and desire doesn't necessarily come first either. I'd like to make a plug for that. It's often arousal that comes first, but for women who have never used a sex toy or a device, understand that you can, and that it can be helpful for anxiety and sleep and just dealing with life's stressors. And it can make you feel good all over, and if you're getting good sleep and you have a reduction in your anxiety through the use of a product such as a clitoral stimulation device. And these also can be used with your partner as well. So they don't have to be used solo, but they can be brought into the bedroom just to spice things up, because I deal with a lot of patients with low sexual desire as well. And they've been in a long-term relationship, and it's that old you again, honey, just doesn't work all the time with the same person. And so this can actually help to spice things up. And it's just important that women continue their sex lives through midlife and beyond, because it's important for overall health as well.
Absolutely.
Yeah, it's so
Absolutely.
important.
Yeah. And I dare to ask this question, and we may not have enough time to cover it, but do you find, or what is your recommendation for someone, whether it's the woman introducing a toy into their relationship, or concerned that the man may not accept that they want to introduce a toy into the relationship? Like what you just mentioned, stress. I mean, it's good for vaginal, all of the things that you just talked about, that makes logical sense to me. But I would imagine that there are some cases where that may be an uncomfortable intro for people. What is your recommendation there? Like, how do you pitch that?
Make sure you're in a relationship with a very confident person.
Yeah.
Because it's not, I think it's easier to bring it in if in a same-sex relationship for two women that are in a same-sex relationship, but also women in same-sex relationships experience orgasm at a much greater rate than in a heterosexual relationship, according to research. But so I understand that, and I hear that from my patients. Oh, my husband would never want me to bring in a sex toy. He wouldn't want me to know that I'm using it. He'd think he's not enough. And so it's really not about that. It's just having that conversation, basically around, would you like to spice things up in the bedroom? And, it's taking a little bit longer for me to experience orgasm now that I'm 51, average age of onset of menopause. And so this is something that could help me. It's not that I'm not still not attracted to you or not still in love with you. I am, but this might actually make things nicer in our lives. And and it's a conversation, I think, that could happen outside of the bedroom long before. Sure. And it's, how do you feel about that? And it's also, having that open communication with your partner, just about their fantasies, their dreams, their desires, and yours as well. And so it's very important, not to just make it duty sex, or, not to just do it to get it over with. But for women to actually enjoy it. Sex is for women as well. But we've been socialized to serve the man, and I hear that a lot from patients of all ages. And so it's very important that not only women come first, well, not that women come as well, but women come first, in fact. But so it could be a conversation that's broken down into many different conversations.
Love that.
Yeah.
Thank you. I think we could probably just make it easy on ourselves and say, you want to spice it up, and most people would be like, yes.
Yeah.
I love it. Thank you.
Yeah.
Christine, I know you had some really,
always like a deal. No.
Yeah. Well, thank you for bringing that up. That's important, and an important part of this. Yeah.
It is so important. Like my brain's ticking, and I'm thinking, gosh, like it's such a huge transition for a woman, and probably a little bit for a dude too, but it's such a huge transition, this whole perimenopause, menopause thing. And, it's not just about the hot flashes and the night sweats. It's like, it's your relationship, and sexual health it is really important.
It isn't. It's
Really.
about low libido. I see a lot of patients in my clinical practice who present with low libido, and but also, I see a lot of patients who, they may have an elevated thyroid stimulating hormone, and that has to be resolved, but they have fatigue, and they might have night sweats, and they might have, joint aches, but those can all go along with hypothyroidism, and so it's very important that you have a proper assessment at perimenopause if you're experiencing any symptoms, and have the right blood work done, and have all the right testing done, and a family history and your own personal history as well. Very important to have all of that done before making a decision on how to manage the transition. But, a lot of women don't know what's happening to them for a number of years. They're experiencing, joint and muscle aches, and they're waking up at night, and they don't think perimenopause necessarily.
Sure. That's so true. See it all the time. That was my experience as well. So
Yeah.
Christine, did you have some other questions on that? Are we ready to dive into
Oh, we could
the
talk about
HR?
that all
I
day,
know
really.
I'm game for that myself, but
But yeah, no, I just want to dive into the HRT thing, because as we were saying before we started recording, I mean, and Carla, you would know, I mean, the whole HRT debate I just find it's huge. And, we work on social media, you're on social media, and you see that there seems to be these two camps of like no HRT, HRT. And then this idea of like, I would like you to shed some light on the difference between HRT and BHRT as well, because I'm not exactly sure
There's a
what
lot there.
bioidentical, like, what is
Oh, go
that?
ahead. I'm not sure that the camps are HRT and no HRT. I think there's evidence-based HRT, and HRT as long as you sign up for a $1,500 US clinic appointment with me. And so they're promoting, there's a lot of influencers online, and they're physicians. They are promoting, the sale of products, which is, borderline unethical. And it's very expensive. It's very elitist medicine, but it's very much, push HRT. And we get a lot of women in my clinical practice that come in and they'll say, I saw this on social media, I've gained weight in midlife, and so I want hormone therapy. And so basically, just quickly, the difference between hormone therapy, or HRT, as you say, hormone replacement therapy, we're kind of going toward more just hormone therapy, or bioidentical, the BHRT. Is the bioidentical is typically, it's a marketing term. It's typically considered compounded. It's going to be more expensive. It's unreliable dosing, and you don't know exactly what hormones you're getting. Whereas the hormone therapy is actually bioidentical and it's regulated.
Oh, really?
And tested. Yes. But as I say, that it's used as a marketing term, the bioidentical. It's very confusing. And women will come in and they'll say, I want bioidentical because I want natural. And so it's not necessarily natural, but you can use the term natural because there's no regulations around using that term either. So it's always best to go with evidence-based, and to go what has gone through the rigorous clinical trials. And so that would be the hormone therapy. And, I find a lot of women, they're paying 3 times the amount to have it compounded, and they might be getting 2 or 3 different types of estrogen in that compounded medication, or they're getting the hormone therapy, that a doctor would prescribe as well, versus the naturopathic doctor. And it's the same one, but they're paying much more for it because they're getting it through the naturopathic doctor. So it's best to go with what has been trialed, and simply put, saying that. And then in terms of the, there's this huge momentum around menopause and hormone therapy, and that it's a panacea for everything, and it's the be all end all, and it's not. And many women will get bloating from estrogen, or they will gain weight after going on hormone therapy. There's also this misinformation that estrogen, they talk about estrogen. I listen very closely to what they're saying, because and I've been in the media for 14 years, so I get that messaging. And when they talk about hormone therapy, some of these influencers, they talk about estrogen. And yes, there, according to the Women's Health Initiative study, there was a reduction in breast cancer risk by about 40% with estrogen alone. That's for women who don't have a uterus. So combined, there is an increased risk of breast cancer for women who need combined hormone therapy. And that still has to be assessed by a physician. So to see a physician say on social media, hormone therapy is for every woman, and to include the vaginal health, with the vaginal health hormones like the cream or the tablet or the pill in that, that bumps it up to 70 to 80%, but that's localized. But the message that women are getting is that every woman should be on hormone therapy. There's no evidence to suggest that it reduces dementia or cardiovascular disease. And what will reduce dementia or cardiovascular disease is the work that you do, Christina, just around nutrition, around alcohol reduction, around getting appropriate sleep, around exercising, getting the blood flowing. But nobody wants to do that. Well, they do. But I mean, a lot of women want the quick fix. And, and they'll come in as well and say, my book club, they're all saying I need hormone therapy. Are you having any symptoms? No. It's symptom management. And I think that's what's coming out a little bit more on social media is evidence-based treatment, menopause, perimenopause, menopause treatment. And it's very nuanced medicine as well. It's very personalized treatment. So you really need somebody who is skilled in assessment and dosages, how to dose this and which products to choose versus just come into my clinic. It's going to cost you $1,500. I'm not sure they're prescribing, because I think they have their licenses to protect. I'm not sure they're prescribing hormone therapy for every woman that walks in there, because they just simply cannot. But they might sell a weighted vest and they might sell supplements. We're seeing a rise in cirrhosis of the hepatitis cases, actually, from the increased supplementation that women are taking. It's you've got to go back to basics in midlife. It's about nutrition. Number one, it's about alcohol consumption. You are at greater risk of breast cancer from alcohol consumption than you are from hormone therapy. And that surprises a lot of women. I'll have women say they don't drink very much, and I'll ask them how many, and they'll say, 14 drinks a week. That's a tremendous amount for a woman. And, so we have to get back to healthy eating, no processed foods, sleeping well, cutting down or cutting out alcohol, because it's very bad for the brain, especially alcohol and sugar. When you're drinking alcohol, a neuroscientist explained this to me one day when we were at an event, and he said, when you drink alcohol, it gets absorbed into the GI tract and gets reabsorbed into the cerebrospinal fluid, and then you go to bed and your brain is bathed in alcohol throughout the night. And you can see some people have depression 8 days after alcohol. They experience a lot of depression in perimenopause. That's why antidepressants are, they are a treatment for perimenopause symptoms, but you've really got to suss out how a person is living. What are their behaviors? What's their lifestyle like? So I cannot overstate just how much alcohol will contribute to dementia, and also sugar and, carbohydrates and, just an unhealthy diet. And so I think in physicians as well, good physicians will start with conservative measures always before moving on to any type of medication or prescription. And that's kind of the way that healthcare is going.
Wow. My mind is blown.
That's a lot. When someone is considering HRT or just has questions, like, first of all, is there something that we need to be looking for in the bio, if you will, of a provider who is well versed in the arena of HRT? And once we find that person, or if we're just talking to our current provider, what are some questions that we need to be asking to see if they are the right person to help us to really understand it and whether or not it's for us?
I think a good place to start is with your GP, but even stepping that back, I think a good place to start is journaling about your journey. Documenting your journey. What symptoms are you having? Write it down. There is a journal that's been developed by a physician, Meno Medico. And so it's opportunity for women to write down their symptoms, their feelings, their experiences, and it's awesome. And so going into your GP with the information, clear information, is extraordinarily helpful. And then that can even be downloaded into your own health record, into the EMR. And that's a place to begin. And then it's, women are smart, and you can say, I've been doing a little bit of research. I've been reading some work of Dr. Jen Gunter, for example, and I'm curious if this might be, perimenopause, menopause, how is it impacting the quality of life? Are you experienced with treating women in perimenopause or menopause? And, that's a question to ask, and doctors don't know everything, they know a lot. And sometimes they will have to look things up, and there's no shame in that. I've worked with doctors for years, and they're like, I'm going to research that and I will get back to you. But they have critical thinking skills because of their training. And so they can very much get up to speed on these things. And they also have colleagues which they can refer to. So it's a very good place to start is with the GP. That said, if you're feeling dismissed, and, some women feel dismissed, I was in with a patient and she came in, she had low libido, she wanted testosterone right away. The doctor said it's not approved. There are other things. It's really a biopsychosocial model approach to low libido. And the woman said she felt dismissed. But doctors have to think of their licenses. But if you do have an experience where somebody just says, you're 45 and they say you're too young for perimenopause, or if they, say, I don't believe in hormone therapy or something like that, obviously it's time to seek out another opinion on your symptoms.
Yeah, you've got to be
But
your
also,
own advocate.
The allied health professionals are very important as well. So seeing a pelvic floor physiotherapist, seeing Christina, for nutrition counseling, seeing an exercise coach, even seeing a life coach, could be helpful. Seeing a therapist can be helpful, because a lot of women experience anxiety at this time, or midlife weight gain they might experience. So, it's not just the GP, but it's also, because this is actually a team-based approach. I'm a registered nurse continence advisor. I see, many of the patients in the clinical practice that have perimenopausal symptoms because I do the assessment, and and then I collaborate with the physician, and we move forward in that way. So, but not all GP practices have that, have that in their practice. So
Sure, that makes sense. Thank you. Christine, did you have other questions on the whole HRT front? That's one thing that I talk about all the time, Maureen. So I really, really appreciate Christine said that her mind was blown. Mine is too, because I haven't really dug deep into HRT. In fact, it's something that I generally choose not to talk much about because I just don't have much knowledge. So thank you for sharing your knowledge with us. Really appreciate that. But Christine, anything else on the HRT side?
Well, it's interesting that you said that about heart health, because there's one very influential medical doctor on Instagram, and she always says that estrogen is protective and helps prevent heart disease.
Estrogen may be cardioprotective, but we don't have the evidence. The guidelines are up to date. A lot of those influencers say the guidelines aren't up to date, but they are. The science is up to date. Do we need more research into menopause, perimenopause, postmenopause? 100%, absolutely. Are there some things that one can do to reduce their risk? 100%. Getting healthy, having a healthy weight, eating a proper diet, getting the right amount of sleep, managing your issues in your life. That's something else. A lot of women come into perimenopause having experienced trauma. Very important. There is some limited research to say that women who have not resolved that trauma or dealt with that trauma will have a more difficult time in that midlife transition to menopause. And so, very important to deal with your relationship issues, work issues, financial issues, because all of that can become overwhelming. Don't forget, women are incredibly busy at this time of life, typically having kids between the ages of, if they have children, 10 and 16. It's brutal, those ages, and they're working inside and outside of the home. They may be renovating if they're fortunate. Or they may have financial problems. It's a very challenging time of life. And then to add not feeling well in any way onto that is critical, that we modify those behaviors that we can before seeking out something that may put weight on you, keep you up at night, and not help you enough with your hot flashes or night sweats or bone density. So that's why it's very nuanced medicine, and it's very comprehensive care. And we need a multitude of educators and nutritionists and exercise experts to help to deal with it.
Yeah,
Oh,
that's
fascinating.
so true. Yeah. So just quickly, so tell me, what's the deal with testosterone? Because I was like, ooh, maybe I need testosterone, not for libido. I'm okay with that. But
Yes.
I keep hearing people say, oh, I've got my motivation back. I've got my energy back. I've got my drive back.
Right.
And but we can't. So Carla's in the US. You're in Canada, right, Maureen?
I am, yes.
Yeah. So you and I are in Canada. So what's the deal? What's the deal on testosterone? Can we get it? Can we not?
Well, it's not approved for use for women in Canada. That's
Okay.
not to say that there aren't doctors who who won't prescribe it. There are doctors, some doctors will prescribe it. Let's not forget about the placebo effect of anything. I can tell you
Okay.
to walk 20 times across your living room floor every night to deal with your hot flashes, and you might notice a reduction in hot flashes. So there is definitely a 30% placebo effect, because especially if you're paying for it, which, since it's not approved and it's typically not covered by insurance, so women would be paying for it. Again, we need more research on that. There isn't the evidence to support it, because women were only entered into research about 25 years ago. And so we weren't even in clinical trials, and some medications for women were tested on men. It's just, the world isn't fair. Do we need, much more research and much more money, funneled into this arena? Absolutely. And then maybe we'll have that evidence to support that it will work. There's a lot of issues, liver issues around turmeric, which a lot of people take, but it can cause liver toxicity. But we don't have any research around that. We don't have any evidence. So people take it and think the more I take, the better it will be. But whereas they'd get a lot more benefit if they ate healthy and, walked 30 minutes a day.
Yeah.
The
Okay.
basics.
That's so good.
There are a lot of
So last,
claims. There are a lot of claims on social media that aren't necessarily true. And you do have to look, how are they benefiting from this?
yeah.
How is a person, and I don't mean to say it's not okay to sell a program or to sell a product, that you fully believe in and that you understand, will benefit women, but to make up stats and to use white papers as clickbait, and, to have, a paucity of evidence to support a claim like a weighted vest, for example. There was they were being pushed, or they still are being pushed quite a bit. And I don't like to comment too much on social media, but I just had to say, for women with osteoporosis or low back pain or scoliosis, this weighted vest is not for everyone. And I just got a barrage of comments from women who said, I tried it, my back pain worsened. I can no longer walk. Okay, we have one right here.
I thought I was going to have to go into traction.
Because they never tell you have to give all of the information. Nothing is going to work 100% for everybody.
Yeah.
And you can't say this is going to increase your bone density when it might increase the bone density, but on the way, I've actually got, a bulging disc. So, and there's no evidence to support that just walking isn't gonna, increase your bone density versus walking with a weighted vest. But we have to be forewarned, and even like your estrogen or localized estrogen therapy, estrogen for vaginal health and bladder health and recurrent urinary tract infections, it works 65% of the time. I hear I see it all the time in my practice. Women are on localized estrogen, but they're still getting urinary tract infections. They're reduced, but they're still getting them. So it's no guarantee, but I see that on social media that says, if you use localized estrogen in your vagina, you will not get recurrent urinary tract infections. That's not true.
Gotcha.
Yeah. Yeah, you have to be so careful.
Yes.
Okay, last question. So I remember last time that when we talked on your podcast, so snapshot of the Women's Health Initiative, and then the flip. It was wrong. We now say that HRT is protective. Can you just give us some
Well,
clarity on
I think that was a media spin. First of all, it wasn't about the year 2001 or two, and it was stopped early, but the media got a hold of estrogen, and the headline was estrogen causes cancer. And so that was a large, incredibly robust clinical trial. We've gotten tremendous data from that trial. A lot of people will say it was a flawed study. There were flaws, but it wasn't that it didn't give us tremendous information. And the pendulum has swung. It went as a result of that Women's Health Initiative. Doctors just stopped prescribing and being educated about hormone therapy. And then, I mean, to be honest with you, I've been holding events since 2010, 2012 about hormone therapy and menopause and educating women about it. So this is nothing new, but all of a sudden a lot of people have gained traction on social media, so they feel that it's new. But I've worked with a lot of doctors educating women about hormone therapy and the actual risks about it. But the pendulum has swung. And for people who are on social media, guess what? Not everybody's on social media. I actually meet women who are not on social media and don't know any of this. There's this message that everybody deserves hormone therapy and it's safe for everyone. I have women in my clinical practice who say, I'd never go on hormone therapy again. Or combined hormone therapy, it gave me breast cancer. And, this is whether it did or not, that is their perception. That is a risk. And, that's why I say going back to nuanced treatment, personalized medicine, a proper assessment, understanding the risks versus the benefits, and just actually having the guidelines. The guidelines are up to date, and that's what a physician should adhere to. Occasionally, clinically, doctors will try something outside of the guidelines, to see if it works. That begins usually with a very desperate person, and they'll try something and then they'll see, oh, this is having some benefit. So there is some of that leeway as well. But for the most part, the pendulum has to come back into the middle. But I think one thing that has come out of it is the vaginal estrogen, so important for so many issues in life, like incontinence and vaginal dryness, painful sex, recurrent urinary tract infections. That's safe and effective for all women. For the most part. Now, not all women may want to take it and use it. And I have a lot of women who say, don't want to try any hormones. And fortunately, they have other options like a personal moisturizer or bi-mouth tablet. That's one great thing that has come out of it, because that can really be debilitating for a lot of women as well. And once you deal with that, then you can deal with the other issues that you have in life.
Sure.
Yeah, absolutely.
Wow.
And
Ton of information.
Like the night sweats and hot flashes, women will tell me if they reduce their alcohol, their night sweats reduce. I hear that 100% in my clinical practice.
Yeah.
Well, I love the as we wrap out, Maureen, I love that you're bringing obviously your medical background into this, but you're also wanting to get down to the basics and understanding. You've talked about different tests that you can take a look at to kind of get a baseline of where you are, and different solutions other than, you mentioned earlier, like an antidepressant, for example, can help someone in menopause, but that may not be the answer for everyone. I really appreciate your approach. Certainly appreciate your knowledge and your time for coming in and chatting with us today. It was great talking to you. It was great meeting you. We'll make sure that the folks have ways to get in touch with you. Make sure that you check the show notes. It's going to have everything there, because we want to make sure that they connect with you if they've got further questions or just want to keep following. She's got some really, really fun things happening on the Instagram. I think I might have seen you also on Facebook, but make sure that you're following her. She's a wealth of knowledge. Maureen, anything that you want to share with us as we wrap out for today?
Thanks so much for having me. I love talking about this subject. I do want to say, you mentioned something about tests, and there are some midlife tests that and women should know their blood pressure and their TSH and their
Yeah.
vitamin D levels and B12, and because they're attached to energy. And but I mentioned earlier on in the program that treatment is symptom based. It's symptom management. You don't need blood tests. You certainly don't need expensive blood tests to check your hormone levels to see if you're in perimenopause or menopause. For the most part, women don't need that. Occasionally, a few hormone tests are done, but it's not routine, and it's definitely not. And again, some charlatans will try and sell you these expensive tests, and that are not necessary. It's about your symptoms. That's why it's important that you document your symptoms and keep a journal of that. So
yeah, thank you for clarifying that. I appreciate that, because I'm not going to say that I've been victim to that, but I certainly have been kind of sucked into I need to pay X dollars for this incredible panel of tests.
And it's going to work because I paid $1,000 for it.
Yes, yeah. So it's a great perspective. I appreciate you sharing that and clarifying that for us.
You're very welcome.
And I'm just glad that you're on social media, because we need more experts like you on social media telling the truth about, these things that nobody wants to talk to, like vaginal health, and the real story around, HRT versus lifestyle and all of that. So appreciate you for being there for us all.
My pleasure. I want to share one funny story. I have a million stories, of course, because I've been seeing women for, 15 years of my clinical practice, and about sexual desire. And this woman came in and she said she was married for like 18 years. She was working inside and outside of the home, driving the kids all over the place, tired. She said, I have no sexual desire. And so we talked about it and talked about the biopsychosocial model and the whole thing. And she went on her merry way. And then she came back a few months later and she said, and I'm not condoning this, but it's just interesting. She said, I wanted to come back and tell you that I realize I have sexual desire. And I think all women have sexual desire, but sometimes it has to be cultivated. Hers wasn't cultivated in the most respectful way, but, she said she went to New York on a girls' trip and she met some guy on a dance floor, and, she was wildly attracted to him. It was just something new and different. And, but sometimes that's what it takes, even just to, reawaken your sexuality. But it takes good health to be able to do that as well. And that's good vaginal health, good heart health, good brain health, good nutrition, and to reawaken that. And so she was ready to, she hadn't actually crossed over in her mind, but she felt that, that it was there and that it could be cultivated. And I think that's a great message for women, that, your sexuality, you're a sexual being, your sexuality is there. Reawaken it. If you need to, lose a little bit of weight or increase your exercise or do more social things or have some self-care or bring a little toy into the bedroom, whatever it takes, it's important that you remain a sexual, healthy being for your life, because, life and sex are to be enjoyed, certainly not endured.
That's right.
Yeah. Absolutely.
Thank you so much. We love stories. We appreciate that. I think that will be there. I'm sure someone will find inspiration behind that story, that they, they might just need to change things up a little bit. So thank you, Maureen, for showing up with us today, for sharing your knowledge. We appreciate you being here. We say thank you for everybody that is listening or that is happening to watch on Facebook Live. We appreciate you. Have a great rest of your day and your weekend. We'll talk to you soon. Take care. Bye-bye.
Thanks, Maureen.
Bye now. Back to work for me.